I'm Dr. Sunita Shamsundar. I'm chairperson of the Fogsi Gynae Oncology Committee, and we are here for the 71st episode of Gyan Pravah, which is a series of the podcast, which is actually a flow of knowledge. So Gyan Pravah is termed is the term that is given for the series of podcasts that we conduct every day under the tenure of Madam President Dr. Sunita Tandulwadkar. Dr. Sunita Tandulwadkar has been she's the president of Fogsi for this year, 2025, and she's been a revolutionary president, I must say, with so many activities planned during her tenure. In the just less than 3 months, we've had so many programs launched. One is the Sampurna Swasthya Janma Abhiyan, that is for preconceptional care of these women, that every pregnancy should be a planned pregnancy. KYN, that is know your numbers. So every woman should know her numbers that for a healthy life. Do Tike Zindagi Ke, that is to increase the awareness in the public, in the doctors, in the healthcare workers and the girls about the cervical cancer vaccine. Ethical and evidence-based recommendations, again, which is a series of EEBR, which is on all the important topics in obs and gynae. Again, a very vital source of information. Arogya Yoga Yatra, making us all realize the spiritual power of healing. Swasthya Nari Abhiyan Yatra, these are the latest initiatives of Madam on breast and cervical awareness program from Kashmir to Kanyakumari. Blood donation initiative, and the slogan for this is people live when people give. So these are some unique programs which Madam has launched, and every day there is something new coming up. And so I think we have something planned for the World Health Day on the 7th of April. And so thank you so much, Madam, and this podcast series is also an initiative started by Madam Sunita.
Thank you, Sarita. Thank you for your so kind words. Most importantly, I need to congratulate you. You got Dr. Vinod Paul, our Niti Aayog member, on the podcast. Sir, this is a beautiful way. My all committee chairpersons are trying to get best of the faculty and having a 30-40 minutes special dialogue with him or her. They try to come out with a beautiful subject, which is for the interest of our Foxians and common people also. Because this podcast goes on YouTube, Instagrams, and all the Foxys of social channel. And many a times it becomes an awareness of the public as well. So thank you so much for coming in on the Foxy platform, sir. And as our protocol is, both of you will be having the dialogue, and I'll be watching you from the viewers link, sir. So I take your leave after your introduction.
Thank you, Madam. Dr. Vinod Paul has served as the faculty of the Department of Pediatrics at All India Institute of Medical Sciences, New Delhi from 1985 to 2020, and he was the head of the department for nearly a decade. He is globally recognized as a medical scientist and a public health exponent. The Government of India appointed Dr. Paul as a member of the National Institution for Transforming India, that is a Niti Aayog, in August 2017, where he heads the health, nutrition, and education verticals, which are very important portfolios. He has played a pivotal role in formulating the Ayushman Bharat, that is PMJAY, which is a very well-known, a very popular program, the Ayushman Arogya Mandir scheme, and the Poshan Abhiyan. Professor Paul also served as the chairman of the Board of Governors in supersession of the Medical Council of India in 2018 to 20, and this tenure was recognized for a record increase in the undergraduate and postgraduate medical seats and introduction of telemedicine guidelines, district residency scheme, and a plethora of other reforms. So Dr. Paul has been part of the core team of the Union Government for COVID-19 pandemic response, and he chaired the National Task Force on COVID-19, the Empowered Group on Emergency Management Plan and Strategy, Empowered Group on Vaccination, as well as a National Expert Group on Vaccine Administration for COVID-19. And we all know so well how hard he worked during the COVID-19 pandemic. Professor Paul has over 400 scientific publications and an H index of 62 to his credit. He's featured among the world's top 2% scientists in the field of pediatrics. And according to a study conducted at the Stanford University in 2020, He's a fellow of the all three science academias of the country and a recipient of the preeminent Dr. B.R. Ambedkar Centenary Award for Excellence in Biomedical Research by the ICMR. Dr. Paul was also conferred with the prestigious Ayan Dogramasi Family Health Foundation Prize by WHO in 2018 World Health Assembly for his globally recognized service in the field of family health. Thank you so much, Dr. Paul, for joining us and for agreeing to spare some time for the Fogsi members.
Thank you.
Thank you, madam.
Thank you.
So, sir, let us this will be a short interview for you. So, you've been a clinician for so many years at the All India Institute. So, what made you join the Niti Aayog, which is mainly a managerial post? So, rather than being just being a clinician.
Well, thank you, Dr. Sarita. And so thank you, Dr. Sunita Tandulwadkar, for the opportunity. You're doing very impressive work. Fogsi is an extremely important organization for our nation. It has contributed over a long period of time toward the health of women and health of children by your academic work, by advocacy, and by educational activities, and so on and so forth. So I'm very honored to be here. Your question is, why did I land in Niti Aayog? Well, my journey, professional journey, has been at AIIMS, very sacred temple of learning that I had the opportunity and the blessing of parents and Almighty to be there since 1972, when I joined as an undergraduate student, and then moved on to do a post-graduation and had the privilege of joining the faculty in 1985. And I ended up, by choice, in neonatology as the area of my work, because our department was fashioned around subspecialties, and neonatology was already a separate unit. And with Dr. Mehban Singh, I joined the unit and developed in my own way the specialty and the care of newborn babies at AIIMS. But as I evolved, I recognized the need for public health dimension to neonatal health, which means that there is a neonatal health that's given and provided by the family, by the frontline workers, the nurses, and general physicians, and then specialists, and then there perhaps some role for the super specialists to be providing high-end care, doing research, putting new pathways, and so on. So I could see that neonatal care cannot be imparted by the specialists or super specialists. And so I could sense the public health dimension. And this debate was already going on in the neonatology circles led by public health conscious neonatologists, pediatricians of our nation. And I could grasp that. And so therefore, gradually had a bent of looking at child health, newborn health through the lens of public health. This was also a time when the diarrheal disease control program for children in the late 80s started. Pneumonia control program started for children, and immunization programs were being done, and nutrition was an important area. So there was this buzz of public health wedded to child health and newborn health, and therefore did a few things that were aligned to the public health solutions for newborn health, by extension child health. And that portfolio sort of grew in my work without absolutely compromising the hardcore neonatology, which I enjoyed doing it. And in that regard, it's very privileged to bring in neonatal ventilation into the country, neonatal resuscitation program, the kangaroo mother care, and so on. So several initiatives in that regard happened. The survival of newborn babies at AIIMS improved systematically, we toyed with different ideas, we moved, and we could reach the levels of survival for small babies and sick babies, comparing with the very best, gradually with the very best. But the public health dimension caught the imagination of a lot of people, and I had the good fortune to then work with the government from time to time, work with various programs focused on newborn babies. The district newborn care program, for example, the newborn resuscitation program, GSSK program as it was called, and then we built on to have facility-based care, home-based newborn care, which was crafted in Gadchiroli by Dr. Bant, which I had the privilege of extending technical assistance and partnership and so on. So grew with that, and therefore that led to a public health oriented academic in me. Then in the wake of the MDGs, there was a global traction on newborn health because one of the MDGs was reducing under 5 mortality by 50% globally. And then soon some of us made it clear, made it evident to the global community that more than half of that is neonatal mortality. And therefore you have to focus. This was really not understood globally. We in India had already understood, as I said, that we already have leaders who are talking about that dimension in India. But globally, newborn was seen as an appendage of the mother for a long time. But when this MDG came up, then it became clear that action has to be taken. So along with very distinguished other colleagues, 3-4 other academic colleagues, so we really worked very hard on bringing advocacy for global health, focused on newborn health for the first time in any time. So we created a neonatal health series, a newborn health series for the Lancet, which provided very high visibility for the need of newborn care, starting with maternal care and then intrapartum care and the postnatal care. So all these ideas started to become more strong, more consensus driven and more complete when this debate became global. But India had already taken a lead, I must say. For example, there was a program called Integrated Management of Childhood Illness. India said, we all said, no, it has to be integrated management of newborn and child health, because that's much of child survival. So India actually was leading this discussion about the importance of newborn health. And so from there, the journey then became more international and global at various fora, the highest fora in the early 2000, going up to 2005. So this public health aspect became very, very strong. I was associated with all the guidelines about newborn health for almost 2 decades, for everything that was done for newborn health. We were there. We were also fortunate to have had WHO Collaborating Center at AIMS, which provided us a platform globally for, again, the public health dimension on newborn health. So all this was happening and simultaneously grew to understand health systems, universal health coverage. I was part of a very path-breaking report commissioned by the then Planning Commission on universal health coverage for India. And this high-level expert group on UHC, I was a member of that. So I grew even more in the health systems expertise. So this was something which I enjoyed doing it, and I perhaps contributed to some extent, made use of it, was an advocate of all this. And therefore, at some point, the government of India, the Honorable Prime Minister, decided that I should be part of the Niti Aayog, which is the National Institution for Transforming India, which is the apex policy think tank of the government of India, chaired by the Honorable Prime Minister. So that took me to that position. It wasn't that I want to be there. It is just the leadership thought that I have the attributes to be able to make a humble contribution toward the policy of the nation. And I discharged my duty to the best of my ability.
That's wonderful, sir. Sir, generally, when we are in the clinical we are in hospitals and in the clinical setup, we generally think that, the policy makers are detached and they're not, so so does the clinician's role actually matter in policy making? So,
Well, we must appreciate that there is the policy encompasses all aspects of that sector. So in our health sector, it encompasses the care that is delivered by clinicians, the clinical care. So it has a place because the nation expects clinical care to improve in every department, every specialty, every subspecialty, and encompassing along the life cycle, and from womb to the geriatric population. So policy addresses that issue, but policy also addresses the pathways to improve health at population level. Basic difference is the following. When we are working as a clinician, which I have been lifelong, clinician and teacher lifelong, we are looking after patients who are coming in contact with us, to reach your office, my office, reach the unit, reach my OPD, get delivered in my institution, and so on. So when we are treating them, then this is called individual care.
yes.
I am responsible for that patient, that group of patients, and I do my best.
Yes.
But then when we are looking at the public health dimension, then we are looking at population as a denominator. How will I change the status of health of a district or a state or a nation? How do we change the health of everyone above the age of 30? Because 30% of them have hypertension. How do we address that? And that dimension does not necessarily have only individual care as the path.
Right. Yes.
It has a prevention dimension. Okay. If it cannot be prevented, it has the secondary prevention dimension, means screening.
Yes.
And then acting upon that.
Yes.
It has a dimension of how to mobilize a behavior change on scale so that illnesses don't happen. How to promote, let's say, exclusive breastfeeding on scale, that every baby receives breastfeeding. When I counsel 10 people. But how do you bring action together to make a difference at population level? And there, the success of what you're doing is not what happens to the ones who may be visible or visiting our facilities, but success is measured on what change you do at the population level. The denominator is the population. In individual care, denominator is the number of patients that you see that come into your circle. So that's the basic approach, but the two are interlinked. So the policy applies to both aspects. We are working how to improve, for example, the critical care of patients of all shades, medical conditions, surgical conditions, and other emergencies that require critical care, and illnesses that require critical care. So that's policy is viewing that. Policy views how to improve care of individuals with stroke, how to improve care of individuals with cancer, for that matter. But then when we are looking at the public health dimension, it would mean how do I ensure screening for cancer cervix for the entire population, a finite population, but entire population, to see that the screening takes place, the referral happens, and so on and so forth. So policy covers both aspects, the clinical part. Another example could be standard treatment guidelines, protocolized care of a child with, let's say, epilepsy, protocolized care for a woman with osteoporosis, and so on and so forth. So clinical care, how to improve care for individuals with say, urological diseases, for that matter, neurological disorders, and so on. So policy covers both aspects, hospitalized care or individualized care in a paradigm, as well as care at the population level. which encompasses preventive, promotive, curative, rehabilitative, and so on. So it encompasses both aspects.
Mm. So you've been at the Niti Aayog for, I think, almost 8 years, sir. So what have been your significant achievements?
Well, the opportunity that the Niti Aayog provides is phenomenal. As I said, that we are the apex think tank. We are, as an organization, chaired by the Honorable Prime Minister, and that gives us a huge mandate to work with ministries and across ministries. The one unique strength of Niti Aayog is truly to be able to bring silos together, bring ministries together. That's the convening power. The Niti Aayog crafts new ideas, curates them, offers them as policy products, puts out debate around new areas where disruption and new policies, new programs, new efforts have to be brought about. So likewise, we also have a responsibility to reach out to the states, working with them to strengthen their journey for development. And also that's cooperative federalism and also competitive federalism, where you create an atmosphere of letting states compete with each other so that everybody excels and tries to reach the highest level of excellence. So in the phase that I have been serving here, had the opportunity to be able to contribute to several initiatives. I had the opportunity to work with colleagues and with other partners, and of course with the leadership, to be able to help develop Ayushman Bharat Pradhan Mantri Jan Arogya Yojana, as well as Ayushman Bharat Health and Wellness Center scheme and mission. And the health and wellness centers are now called Ayushman Arogya Mandirs. So these are the twin pillars of our universal health coverage, universal health care in the country. One that deals with primary care. That is through the Ayushman Arogya Mandirs, that you strengthen the sub-health centers and primary health centers. Provide a new provider has been instituted, 140,000 of them approximately, who are community health officers. This has happened rather quietly. A silent revolution has taken place. 174,000 health and wellness centers, Ayushman Arogya Mandirs, are operational today, and they are adding their work. They are there now with a new look, with the presence of telemedicine, the new worker, new systems out there, new ways of monitoring it. And we are pushing the frontier as a nation from selective primary care, which was mother, newborn, child health, family planning, and communicable diseases, to incorporate non-communicable diseases, hypertension, diabetes, the 3 cancers, including cancer cervix and cancer breast, and then mental health, senior care, and gradually adding oral health as well as ENT care and eye health. So it's a journey that is ongoing. It's a work in progress, but a very major transformation is happening on the ground. Primary health care through the health and wellness center, the Ayushman Arogya Mandirs, these centers are providing free medicines. At sub-center, more than 105. At PSC, 172 free drugs, and 14 diagnostics at sub-center, and 43 or so diagnostics at the PSC. That's the vision. So the services are put close to the people. We look forward to ensuring that people utilize these services and to help our workers and this platform to maximally contribute toward the good health of women and of course children by extension. So that's one. And then the second limb of Ayushman Bharat, which was both were announced together in 2018 budget speech, under the leadership of the Prime Minister, the PM Ayushman Bharat PMJ provides cover to begin with for 40% of India's population, 50 crore people, providing a cover of 5 lakh for the beneficiaries per annum per family. This cover is now increased to 55 crore people, and with elderly getting included, additional population. And for the elderly population above 70, socioeconomic criteria also does not apply. What I wish to also add to this is that apart from this 55 crore plus, the states have added additional population through their own budget. This is shared budget, where 60% is Government of India, and this is their own budget. And today, using the platform of Ayushman Bharat, half of India's population has assured access to secondary and tertiary care through more than 1,900 packages across the country, through 31,000 plus hospitals, government and private. That's the level of coverage that it has. Free, cashless services are being provided. And I looked at how many people were admitted yesterday. 25,000 patients were admitted yesterday. And since the inception, 8 crore plus people, individuals have been authorized care under the scheme. We are strengthening the scheme. It's not yet fully perfect. Perfection is the goal that we will push for, but it is helping thousands and thousands of people today. So I had the privilege of being associated. I'll be happy to give more details of this if time permits, but this was my humble contribution to have at that time worked to develop these schemes along with very many other important partners, and particularly the ministry, and of course with the guidance of the Honorable Prime Minister. The scheme shaped up, and this is the world's biggest health assurance system on this planet. I also contributed to the Poshan Abhiyan, which repositioned the nutrition of children aimed at reducing stunting and wasting program. That also happened around that time. And then I was also given additional responsibility to chair the Board of Governors for the Medical Council of India, which was superseded. And during that period, we really worked very hard. I had a great team, worked very hard to reform the medical education system. And we changed the trajectory, under the guidance of the government, changed the trajectory of the pipeline for undergraduate and postgraduate seats. The number of seats that happened that particular years were a record. And then, of course, we've excelled further. So that momentum was built. We almost did more than 50 in 2 years' time, 52 new regulations. We simplified the processes. We created this very interesting program called District Residency Program as a BOG, in which in the second year of 3-year PG program, all specialty postgraduates go to district hospital and sub-district hospitals and all sub-district hospitals to serve there and to learn in the context. So by doing this, I get better training because I'm providing care more independent, like the internship. So even more than internship, but we're taking decisions and in the context and working with the team, which are our backbone of our system, secondary care system. And also by doing so, you are able to strengthen the specialty care of these district hospitals in a very significant way. And the kind of numbers that we have, this technically ensures almost 8 to 10 specialists at any given time, and in each one of these district hospitals. Can you imagine? In 8 to 10 specialists are available, gynae, pediatrics, one from maybe pathology and so on, in each district hospital. It's again work in progress. It's not fully mature, but if you deal with the numbers, that's how it is. We also introduced the telemedicine guideline under the Act because there was no legal framework for telemedicine, and it became very handy in the COVID times and so on. Likewise, then, of course, the next phase was largely consumed by the efforts around COVID-19 pandemic. And as you heard and you talked, I had the privilege of leading the National Task Force for COVID-19 and also the NEGVAC, which was the National Technical Advisory Group on vaccination for COVID-19. So through that, we made an all-out effort together with everybody else, with all the stakeholders, to be able to do the best we could for controlling the pandemic, for providing rational countermeasures, for pandemic control and emergency response, and in particular, worked very, very hard to catalyze the vaccination production as well as vaccination delivery in my own humble way. But this is a work done by a large number of people under the leadership of the Prime Minister. And more recently, we are now looking at senior care because India's elderly population is rising, and we have to look at their health, their welfare, their security, their digital literacy, and so on, and their financial sustainability. It's a very, very important area of work. We also worked on future pandemic preparedness. We are working on critical care medicine, capacity development in the country, on brain health, and also early childhood development and care, school health, anemia, and also accident trauma care paradigm for India. These are some of the ideas which are being crafted with the help of the ministry, but more importantly with the leaders of the respective professions and academia.
That's wonderful, sir. Amazing work you've been doing. So in terms of reproductive health, how has the healthcare delivery changed with reforms in the Niti Aayog, and how has cancer care changed?
Well, I think first I'd like to put on record the nation's work in the core area of women's health, namely the maternal mortality ratio. I think we should start there because today is also World Health Day. And this time the theme is healthy beginnings, hopeful future. It's focused on women and children. So today let's highlight what India has been able to achieve in the space of maternal survival, maternal mortality reduction. If you go back to 1990, which was the base year for the MDGs, our maternal mortality ratio was 556 per lakh live births, 556. In the year 1820, which means 20, because it's a rolling average that we calculate, this has come down to 97 per lakh population. From 550, 1990 to 97 in 20. This is a decline of 83% from the baseline. In this period, the global decline is only 42%. India logged a double rate of decline in this phase, and that shows that women's health is a core priority for India. We achieved the MDG, and we will also achieve our SDG with the help of all of us, all of you. SDG goal is 70, and I'm very certain that we are on track to achieve 70 before 2030. What I wish to also highlight that 9 states, even in 2020, have already achieved the SDG. Kerala is as low as 19 per lakh population. Nation 97, Kerala 19, Maharashtra 33, Telangana 43, Andhra 45, Tamil Nadu 54, Jharkhand 56, Gujarat 57, and Karnataka 69. And 3-4 other states are also on the cusp. So we will achieve the SDG, and that should be a cause for great satisfaction for all of us, and particularly to you, because you are the key stakeholder for women's health, and your contribution as well in achieving all this, which we salute. So look at that on this core thing, doing well. On family planning, reproductive health you mentioned, you know that we are now doing very well. We are stabilized our population. Our TFR has stabilized, and already that has been taken care of with multiple measures, which are medical measures, but also literacy, awareness, and overall development, and all the work that you all put together in offering products and giving choices for family planning. But going forward, your point is very valid to have mentioned cancer in particular. I wish to state that I think the highest priority for women's health today should be really to of course, make sure that we ensure highest survival in terms of perinatal survival. We must make progress on decreasing the stillbirth rate and neonatal mortality. Again, we are on track for neonatal mortality, but I think we should also track and do a better sort of performance for stillbirth reduction. Measurement of stillbirth is also an issue, but I want Fogsi to be mindful that stillbirth is the other side of neonatal mortality. This was a baby who was alive till 5 minutes ago or an hour ago, and a clear focus on how to do it and to scale it up in the country should be undertaken. And here, additional visits and prenatal contacts are important in the third trimester, as WHO has proposed. Other than this, I think our priority is women's cancers, both cervix and breast. At times, I feel that the obstetrics and gynecology fraternity should talk equally more for the breast cancer as well, because you get the opportunity to get the patients, but more importantly, also you are the overall top stakeholder for this. But having said that, we are very happy that both of these are part of the Ayushman Arogya Mandir paradigm. Let me explain what it means. It means the following, that here is an Ayushman Arogya Mandir responsible for a population of 6,000. Okay, let's say. Above the age of 30, all women need to be screened every 3 years or 5 years, as whatever you will guide us, as you have guided so far, for cancer, cervix, and breast cancer. They have to be screened. Today, the screening method for breast is palpation, and for cancer cervix, it is acetic acid related test. Not good enough. But we are looking for new ways of diagnosing, including a rapid test using the HPV DNA system, apart from, of course, PEP, which is not easy to scale up. Having said that, time has come that we work together and demonstrate that this can be done, even with acetic acid. It can be done. ICMR studies showed that, look, this can be taught to ANMs, referrals can take place. And I said that from the Ayushman Arogya Mandir, telemedicine is possible, referral is possible. I mentioned that PMJ gives you 1,900 packages. It includes cancer cervix treatment for the beneficiaries. It includes cancer breast treatment, and so on. So today, time has come that we eliminate cancer cervix. We meet the full gap of cancer cervix treatment gap in our nation. It is possible. And I'll tell you, and likewise for breast cancer, I'll come to that in a minute, but let me just focus on cancer cervix first, because that's much more of your direct responsibility. So the catch here is that the diagnostic test, let's say at the moment, needs to be scaled. Training needs to be given to ANMs and, if required, for CHOs. They are at the front line. And the same way in urban areas, the corresponding workers, including, of course, urban area Ayushman Arogya Mandirs. That should happen. And then after screening, the referral has to be made for confirmation. Then treatment has to be instituted. My request to academia and Fogsi is the following. That you demonstrate this, a functioning model of this in your own way. Take a population, let's say Delhi, you take a population of 5 lakhs, let's say. Because in public health, the denominator I said is population, 5 lakh. Choose an area or choose 2 areas, 5 lakh each. We have so many of us in Delhi. You use the infrastructure that we have, system available, let's all unite together, bring public-private partnership, treat them. Most of them in any case will be covered with PMJ. If not, the other systems are available, and then bring them back for follow-up. Likewise, can we demonstrate this as functional model in a rural area, in a district in Maharashtra, for example, or a district in Jharkhand, or half a district in Rajasthan, where we demonstrate the entire chain? Because once you do that, it becomes easy for us to adapt a fully functional, operational, perfect model, but also it becomes an inspiration for the scale up by the states, because our progress on screening has been relatively modest. And we need to create the model. Please appreciate, we have not demonstrated anywhere population-based model by academia or Fogsi. So I urge you कि आप इसको करके दिखाएं. आप population decide कर लीजिए, population में 30 के अबाव करके दिखाइए, फिर रेफरल करो, हम बैठ के बना देंगे. सरकार जहां की होगी उनके साथ मिलके आपको जोड़ देंगे. दिल्ली में करेंगे, सब कुछ है यहाँ पे, आप जोड़ के कर सकते हो. तो आप इसमें जुड़िएगा. सिर्फ एडवोकेसी तो आप हो गया. Cancer cervix is already part of screening, and HPV vaccine also has been committed. It's only a matter of time. It was a commitment made in the budget speech, as you know, last year. It's only a matter of time. वो हो जाएगा. उसमें भी कुछ ऑपरेशनल इश्यू है, उसको भी हम मदद मांग सकते हैं. लेकिन आप अभी आपकी ताकत जो रहेगी, जैसे कि आपने जो मदद करी थी 9th of every month, हम आपकी मदद के साथ में हाई रिस्क प्रेगनेंसी को एग्जामिन करवाते हैं. आप पीएम सुरक्षित मातृत्व अभियान जो किया था, उसमें आप सबका योगदान रहा. इट मेड अ डिफरेंस. So likewise, I urge that we mount this to demonstrate the model and what it takes on a significant population, and that will be a great help. Similarly, for breast cancer. Breast cancer palpation से ही करते हैं. Shadow में है तो mammography से भी हो सकता है. So let's create these models, because that will help us to adapt that to the health and wellness for a sustainability has to be ultimately done through the health and wellness center, आयुष्मान आरोग्य मंदिर वहीं होगा. और आपसे भी रिक्वेस्ट यही होगी कि अगर आप बियॉन्ड सिटीज जाते हैं पर्टिकुलरली, तो हेल्थ एंड वेलनेस सेंटर के नेटवर्क को ही इस्तेमाल करके ऐसा मॉडल क्रिएट करके दिखाएं, ताकि वो प्राइमरी सस्टेनेबल प्राइमरी केयर एम्बेडेड cervical cancer screening and treatment and rehabilitation and continuing care model, both for rural and urban, can be created with your help. This is work that has not been done. I urge you, आप करिए, और जहां पे आपको मदद चाहिए वो करें. टेस्ट जैसे जैसे इंप्रूव हो जाएगा उसको भी एम्ब्रेस करते जाएंगे. लेकिन we need help on this, because unless we create a fully functional model, the coverage increases, quality increases, counseling of these patients improves, continuity of care is imparted, the work and the model is not complete. So I urge you to do that, and you have a very, very important role to play. Likewise for breast cancer, the model based on palpation and full detection and treatment and follow-up using ABHA ID. It's possible now to do it electronically. Let's work together to bring all this together. That is how you push the frontier for creating public health solutions. And then it is for the government to embrace that and to make it part of the policy and the program.
Yes, sir, definitely. I think we can work on this. So what are the plans? What are your plans for the Niti Aayog's plans for women's health for the future?
Well, I think I would say the following. First, we'll really like to work with you, and I hope Madam President and delegation will be giving me an opportunity to welcome you in Niti Aayog. Let's sit down and talk about the priorities. One I mentioned, the others I am going to mention now. Let's work together because you can multiply efforts. Please go beyond advocacy. This government is an action-oriented government. Platform for primary care has been created. Platform for secondary, tertiary, hospitalized care has been created. PMJ paradigm has been provided. Are we getting enough women to seek from the beneficiaries? There are a lot of cancers in that beneficiary. Are they coming in enough number to make use of PMJ? Perhaps not. Because I still hear a lot of other priority packages being used in higher numbers. And please, therefore, let's find ways of creating, demand, creating models, and so on. But among the priorities, I would say, residual priority continues to be MMR reduction. I said focus on stillbirth rate, which is primarily for you to do and to guide us, and of course the system to respond and to see that it can be taken to the level, single-digit level, sooner than later. Next bunch of priorities to me are the following. One, I would say cancer cervix and cancer breast, I've already mentioned. But simultaneously, let me put the next one on the list, anemia. Anemia is the commonest problem of women. Pregnant women, 60% plus prevalence of anemia. And when there is something which is 60% plus, please appreciate that it affects not only the poor, but also the rich and the richest. There's something that we have to address. In any case, some improvements and care and response and coverage has been ensured through efforts because it has been a focus of our antenatal care. And, and maternal survival having improved, stillbirth attendant care having improved, institutional deliveries have increased almost 90%. Clearly, this has been taken care of, the blood transfusions and, iron therapy, and as well as, intravenous iron. There have been approaches. But look at non-pregnant women. Non-pregnant women, all the way to elderly, typically half of non-pregnant women are anemic. And I believe it is valid even when you take the venous sample. So capillary venous is not an issue. You just accept, for the sake of discussion, that it is our understanding that about half of non-pregnant women, these are working women, by the way. These are women, some are pregnant, but most are not pregnant. They are looking after families. They are doing jobs. They are on the field. They are doing agriculture. They are teaching. They are in factories, and so on and so forth. And they have, half of them have anemia. Somebody may say mild anemia has no meaning. I'm not sure. But moderate and severe has a meaning. When your hemoglobin is less than 9, you cannot work. You are tired. You are sleepy. Your productivity is low. Your mentation is affected. Half of anemics are moderate or severe. So 1 out of a quarter non-pregnant women is moderate or severe anemia. We need to find a way. I want your voice on this one. How do we do it? How do we do it? It's about nutrition. It's about food. It's about iron coming from, ultimately it should come from diverse food. We need your help. It should be about perhaps supplementation. How much? To all? To some? And by the way, the proportion for anemia increases with age. And I'm going to come to the elderly woman as a priority in a minute. Then do we need to test? If I test and find that I'm anemic, get tested and find anemic, I have more motivation to take the capsule on a daily basis. Do we go for that strategy? What do we do? And there is some proportion of us which are thalassemia minor and other problems, the chronic anemia, chronic infection as a cause of anemia, and so on. So this cause of anemia among non-pregnant women should be your concern also, not just the concern of, let's say, hematologists. or others? No. It's such a major disease. Look at the burden. It's the commonest problem, if I venture to say. I hope I'm right. Okay? Right, because I'm giving you data. And I hope I'm wrong because I don't want to see this level of anemia. Okay? Both sides are true. So I would urge you to think about anemia. It's about prevention. It's about treatment. It's about getting the women to be able to perform better mentally, physically, psychologically, within the home and beyond. So I think that is an area where we need to work together. Next area, I think all of us should think about osteoporosis as an issue. And we have not even started the discussion. I would like to start the discussion with you, with your organization, with other academics as to how to go about handling this. And another area of work is truly also the women's health of the elderly population, elderly women. There's no discourse again on this one. I hope we can generate discussion in the academia on the need for care of the elderly women. Some issues are same, like anemia, as I mentioned, or osteoporosis, or cancer predilection. Some are same by way of non-communicable diseases such as diabetes and hypertension and so on. They're common. They occur at every age. They become more, and mental health for that matter. But some could be unique problems of the elderly, which we, as osteoporosis being one of them, and prolapse, for example, is another problem, and so on. So we should think about what are the special needs of the elderly women, because our population of elderly would rise. Today, above 60, we are 11%. By 2050, it will be double to 22%. And please note also the fact, and that should be communicated, that there are more elderly women than men, because the longevity of women is more than the men. After the age of 70, 68% women are widows. They don't have a partner. And this proportion for men being widowers is much lower. So they are living alone. They don't have a partner. And that imposes, issues of stress and poor care potentially, but also support needs, which may not necessarily come from the family. They should, but how can we strengthen the families to look after their elderly mothers, elderly women? So I would like a debate to go also in this direction, because this is a huge public health issue, even for diabetes and hypertension. How do we handle women in that age? I think you should all start talking about it, because this indeed, and what are the gynecological problems that we should be tackling? And these women also, of course, need cataract care and so on and so forth. I'm just mentioning that let's speak of a women's health beyond obstetrics and gynecology also, because that's what you stand for ultimately. And that should be an important area of work. My last priority I would highlight is the care of women, completing the cycle as a preconceptional care.
Yes.
You see, there is one thing that our children should be healthy, our adolescent girls should be healthy, given. And we're not covering that today. Before the pregnancy happens, there is a period when, before the woman goes to become pregnant, she should be as normal, as healthy as possible for her own sake and for the sake of the progeny. So important. What does it mean? That before pregnancy, my anemia should be corrected. If 60% women during pregnancy have anemia and we catch them in the second trimester and then try to course correct, it's too late. Why not ensure adolescent girls to be non-anemic, non-pregnant women to be non-anemic, but surely preconceptionally non-anemic? We treat them at that time so that you have a good start. If they are undernourished, they have a low BMI because of my morning sickness. I do my job. Government gives you take-home ration, but why not start early? I want you to be votary for this. Can we treat UTI in every mother? Every pre-pregnant woman? during the preconception phase, when we are actually promoting family planning and giving them, those choices, is also the time to look after the UTI, so that once they decide to be pregnant, and that they won't tell you, they don't have urinary tract infection, they don't have hypertension, or it's controlled, they don't have diabetes. It can be controlled. 10% around that time would have diabetes. Okay? And if they're undernourished, I'm repeating, if my BMI is less than 18, I better pick up my weight. Otherwise, baby will be small. I don't have reserve. So I want you to be prioritizing preconceptional care and again demonstrate scale up of this. How do you do it in the government system, in the public health system, at the population level? Talk about this package of preconceptional care, which will improve the maternal survival, less anemia in the mother, and then it will give more survival opportunity for the perinatal, for both for the baby as well as the fetus, and so on. So infection treatment, and you can also look at that time syphilis, for example, which we do the screening or something else, or other infections, RTIs, for example. So treat them, and by this time, so maybe time for India has now come that our action really does not start, in terms of reproductive health care beyond the fertility control, shall we say, but prepares this woman to be fully nourished and good state of mind. That also should be a part of this state of mind, healthy, positive state of mind, comfortable, not anemic, healthy, sleeping well, good nourished before she gets into pregnancy, and you will have gains going into future. And then if you're detected hypertension now, it has gained all the way, because it is such an important issue, or diabetes, which, as I said, is 10% in the population, and earlier we detect, better it is, and so on and so forth. So I think you should consider formulating, well, idea around preconceptional care is not new. What is now important is the time has come that this be made part to push the frontier of newborn and perinatal survival. And today we can afford to push that because we have achieved other milestones. Number two, today is a time when you can now lay weight on this particular approach, because we understand the dynamics much better. But then, where is the model? We demonstrate it. What are the components of that package? How do you deliver the package? How do you ensure that when you treat anemia, you test and treat anemia, compliance is ensured? How do we ensure that we can do an accurate test for urinary tract infection? What we hear all the time, we need more insights into the how part. And there we would like, going back to your original question, going back from individual care, going beyond the individual care, which is so important and which must be instituted and enforced and feel proud of, to public health approach, to see that it happens on scale through the health system that we have, and helping that health system to perform using the primary health care, Ayushman Arogya Mandir network that we already have, using other opportunities in the community public health system that we have, and so on and so forth. And then, of course, using secondary, tertiary health assurance system and care, which is available through the PMJA system and others like ESI and so on, so that the best is now available. Best health is available to our women.
Yes, thank you so much, sir. Thank you so much for giving all the ideas for us. Yes, I think we will come and meet you. We will also, I know we do have various committees, so each of us looking at different parts of the women's health. So I think that'll be a great idea, sir, for you to guide us in this endeavor.
And apart from working with Niti, which I would really hope that you all will come together, or we can have a brainstorming you organize. We'll be there to discuss. But also you may like to work with your state chapters to,
Yes.
to work in different states. Every state needs help. Madhya Pradesh has created a new strategy for maternal survival. You can help them. The other states also need your help. And those who have done good maternal survival, surely, and even otherwise, pushing the frontier of cervical cancer care, it's a nationwide thing. I think, Foxy, you have an opportunity to make a historic difference in 2025 onwards. You have nation's leadership, which is aiming for action, aiming to achieve SDG, and aiming to take India toward the goal of Viksit Bharat. Viksit Bharat goal has optimum health of its citizens, including women and children. So I think you move from the current advocacy education, you do that. But let's build more energies to push and to demonstrate public health approaches to the highest priority challenges that today India faces. I have highlighted some. We can talk more about what you may think are other ideas or to refine these ideas. But come into the open and mobilize and demonstrate. I think an academic organization like yours succeeds doing very well, the advocacy, even capacity, but capacity can be directed toward some of these issues so that it helps on the ground. It's very good also in conducting perhaps research, and, in some areas you may be triggering that. But then when you go beyond this, then you please become a partner for public health delivery in your space. And I have given you ideas on that. That's moving more beyond beyond what you say and the speeches and commitments and so on. Move into action. And today more than ever, we need that. We need you to join hands. And I've given you clear ideas on some of the areas we can discuss, we can refine. You can have your own ideas, but clearly, cancer cervix is something that should now be fully addressed in the next 5 years. We can do it. One cohort, entire national cohort of the vulnerable population above 30, we can done with. Then we have to deal with only the future tests. एक साइकिल तो कर दे कंप्लीट, 3 साल के बाद दूसरी बारी आएगी, खत्म करें इस काम को. दिस कैन बी डन. ब्रेस्ट कैंसर का भी यही कर लेते हैं. तो मैं चाहूंगा कि इसकी तरह से नजर आप देखिए. एनीमिया के बारे में भी सोचिए. प्री कंसेप्शन केयर परहैप्स नीड्स अ डिफरेंट अप्रोच, उसको भी सोचिए. This is my humble submission. I have had in my life a great privilege and blessing to have worked with my great teachers in obstetrics and gynecology and great partners, very, very, very informed and insightful partnerships I had with the obstetrics and gynecological fraternity at AIMS and beyond. As a neonatologist, it has been a privilege. It has been a natural partnership with the obstetrics fraternity. I'm very proud of that. I salute you for your great work. I salute you for the specialties that you are now developing. That's another one. I think it's time that your specialties should shape into DM courses and others. Someday we can talk about that. And we are there to support you. It will be my honor and a privilege to partner with you in my current humble role. And let's work together and give new ideas. Neeti will take up new ideas from you to pursue our women's health. Thank you very much, and greetings on World Health Day 2025. Thank you.
Thank you so much, sir. Thank you so much for all the wisdom, for all the suggestions. Thank you, sir.
Thank you.